Hello everyone, I'm Namita Thapar, Executive Director of MKO Pharmaceuticals, and today is a very interesting topic, pregnancy.
The doctor is going to get 20,000 rupees more in doing a cesarean. That's why he convinced me to get a cesarean done.
So I remember I had both normal deliveries and I was out the very next day.
Don't take stress, be calm.
That itself would give you stress.
Exactly.
Oh God, he's not even giving you a diet. Oh my God, he didn't give you pelvic floor exercises?
It has to be a vaginal birth, the child has to be 3 kilos and the child has to come first in 10 standard.
Your little tummy will stay with
Yeah.
C-section, whereas with normal you can have a flat tummy. All these are myths, right?
I think what is the best is a safe birth.
A skinny pregnant woman was looked down as like hurting the baby by being skinny.
I think it's not a good thing to do.
See, there is a reason why maternity leave is granted for 6 months.
Yesterday, she vomited 6 times, but I vomited only thrice.
Oh my God.
Does that mean her pregnancy is better than mine?
There are 45 million pregnancies in India and 16 million of those choose abortion. It's a fairly large number. There are a lot of questions that we deal with, like is C-section better, normal delivery better, what is RPL, what are the myths and stigmas around this very critical topic. And to address this, we have two dear friends of mine, Dr. Jaydeep Tank, it's his second time on our podcast, and Dr. Jay Mehta, one of the younger doctors with a huge social media presence, his first time on our podcast. So welcome to the two of you. And Dr. Tank, let's start with you. So I want to ask you a question. Let's get to the point. Is C-section better? Is normal delivery better? What are your views?
Namita, I think it's a false equivalence. I think what is the best is a safe birth. It doesn't pretty much matter in the modern era whether it's a C-section or a vaginal birth. And I have this whole problem with talking about vaginal birth as normal delivery.
Okay.
I believe that as obstetricians, we assist birth. Delivery is done by Zomato and Swiggy.
Yes,
We
that's a
assist
good one.
birth. Let's stop calling it a delivery.
Yeah.
I also don't like to use the word normal for a vaginal birth because if we accept that the C-section rate is around 30 to 40%, by calling a vaginal birth normal, you're stigmatizing the 30 to 40% of women, and that's a very significant number.
True.
By telling them that your birth's abnormal. So first of all, I think the terminology around the whole conversation of birthing needs to change. It's quite unfortunate that birthing is looked upon with a very commercial perspective, when actually it should be all about the woman and her choices. I do think that in the modern era, given everything that we have in terms of technology, safety, antibiotics, etc., the choice of whether to give birth vaginally or by C-section should be left to the woman. It is the obstetrician's duty and job to guide the woman through the process, take into account what she wants, and then proceed and give her the safest birth possible. Having said that, there are certain situations where a C-section is required. And I don't think we should shy away from that. I've heard obstetricians sometimes going and telling women who had a section, I'm sorry I had to do your section. And I always tell them, why are you sorry? You should not be sorry. Every time you assist a birth with safety and dignity, you're bringing life into the world. Not only are you bringing life into the world, you're doing it with a certain degree of precision. And I think this is so vital. It's vital to building families, it's vital to building communities, and it's vital for the future of the country. So I think this whole debate between normal and a C-section is a false equivalence. So I'd just like to say that this whole debate started in 1966 when the WHO published a paper where they said that the C-section rate should not be more than 15%.
Wait, they actually put a number?
They actually put a number, which was, I think, at that point of time, maybe it was the appropriate thing to do. But actually, I think they did realize going down the line, given the amount of data, for example, 15% looked only at mortality, which means a woman passing away during birth. They never looked at morbidity. And morbidity, for example, birth asphyxia, problems with neonates, problems with perineum of women, problems with obstetric anal sphincter injury, etc., were never taken into account. And they weren't taken into account not because they didn't want to, it's because the data are not available. And surprisingly enough, that data is still not available.
Okay.
So when you say that our section rate should be X, I think it's almost a wrong thing to say. There's nothing like
There's nothing to substantiate it.
nothing to substantiate it, and there is no way to arrive at an optimal section rate. Every woman is different. Every woman has different needs. Every woman wants different things, and I think you need to respect that with birthing. At the end of the day, it boils down to choices. It boils down to what is medically required, and it boils down to the fact that at some point it has to be accepted that at the end of the day, C-section saves lives. I feel that we are actually stigmatizing cesarean sections. We are talking negatively about C-sections to the extent where women are hesitant to undergo even medically indicated C-sections. And I'm not sure that's good for anybody.
Right.
It's not good for the woman, it's not good for the newborn, and it certainly is not good for obstetricians. Just to conclude, at the end, I think this whole debate about C-sections, vaginal births, normal delivery is a false equivalence. Different things for different people in different situations would be the most appropriate thing that we could do for birthing. Always, of course, respecting the woman's needs, her choices, her dignity, and provide the best possible care to provide the best and more importantly, the safest possible outcome.
Absolutely. And you spoke about medically indicated C-section. So just touch upon that in what cases would a C-section be absolutely necessary?
You can divide those essentially into two. There are some instances where you know before she even goes into labor that she'll need a C-section. For example, there's someone in what is known as a transverse lie, where the baby, instead of facing head down, is lying transversely in the abdomen.
Right.
Well, she can't have a vaginal birth, and you know that she needs that. There are other medical indications like a high and uncontrolled blood pressure. There are indications like diabetes. There are other indications where the child is too big.
Right.
Or other indications where the child is compromised. For example, there's intrauterine growth retardation and so on and so forth. So these are women who undergo what's known as an elective section. An elective cesarean is when you do the cesarean before she goes into labor, usually a few days before she's due.
Okay.
And there are other kinds of sections where you have to do it as an emergency, where she goes into labor and now, for example, she's not progressing.
Right.
There is a certain defined rate of progress by which, so for a vaginal birth, the mouth of the uterus, that's the cervix, has to soften, it has to dilate, means it has to open, and the child's head has to descend.
Right.
If either of these three, classically we call them power, passage and passenger. And if any of these don't occur in the way they are supposed to, then she may need a C-section.
Got it.
And then there are those relatively rare circumstances where you have to do something like a crash cesarean. For example, there is what we call an accidental hemorrhage or an abruption, where the placenta separates, the blood flow to the fetus gets cut off, and then you have to go in and do a section quite immediately.
Right.
Or there's an occasion where the fetus passes stool, and then you have to again do a section. So there are various kinds, but I think the long and the short of it is that when medically indicated, C-section saves lives. And while we focus on the life of the woman and the mother, I think the life of the fetus and the future potential of the fetus to be born well also has to be taken into account and into consideration as much as any other thing.
Absolutely. No, very well said. And Dr. Jay, let's move on to you. I mean, Dr. Jaydeep Tank is in his mid-50s. He's been doing this for a while, so he's seen the change.
Yeah.
You are a younger doctor in your early 30s. What are you seeing? Are you seeing more patients coming to you and just by default wanting more C-section? What are the trends that you're seeing? And what are your thoughts about C-section versus, I won't call it normal, vaginal delivery?
No, categorically, sir has mentioned it, that's been our classical teaching. Mother should be healthy and the fetus should be healthy. As long as you are achieving these two, it's also going to be dependent upon the type of patient profiling which you are looking at. Like, for example, somebody who is really looking into a lot of high-risk pregnancies, he or she may, necessarily have a lot more cesareans being done in his or her hospital.
Right.
I would like to also point out, I think probably we can address this openly. A lot of times patients have this fear that doctors do a cesarean section because doctors want to earn more money out of that.
Oh yeah, that's a good point to address.
I think we need to address this because in most of the good hospitals, like probably Sir's hospital, my hospital, and many other good hospitals across the city or across the country, I think people have realized that, they need to normalize this, and as a result of which, people don't really charge a premium for doing a cesarean section or charge a premium for doing a vaginal delivery. In fact, with the amount of effort it requires to assist a vaginal birth, I think the premium should be for the vaginal birth and less for the cesarean sections.
I'm so glad you brought up this point, because there is a price difference between both, which sometimes people wonder that is there.
And people try
the
to
intent?
think that, the doctor is going to get like what, 20,000 rupees more in doing a cesarean. That's why he convinced me or my family to get a cesarean done. I think from what sir mentioned, one very important thing which all of us could add is, when people are approaching the final trimester, we sit down with them and we discuss out these options with them at the time of they getting registered in the hospital. So they understand that, okay, nothing like this is going to happen, and it's dependent on that day, that moment. And
what the need is.
And that circumstance, because people may lose out, from one, they may skip a consultant and go to somebody else, and somebody else would have said, no, I'll try for a vaginal birth. And what if something happens in that vaginal birth and the next consultant needs to do a cesarean section?
Right. There's no guarantee.
There's no guarantee.
Absolutely. Since we spoke about this, sorry, go ahead.
I have this view about, I know that there are some people who feel, and I feel that it's a bit of monkey balancing, honestly, that if a doctor says, I'll charge you the same for a vaginal birth and a C-section, then that takes money out of the equation. That's an argument which has been made very commonly.
Right.
In a country like ours, where women pay out of pocket, I think it's not a good thing to do. It's a very simple back of the envelope calculation. Whenever you charge the same for a vaginal birth and a C-section, let's say someone charges 100 rupees for a birth vaginally, 150 for a C-section. So you will not charge 100 for a C-section. C-section is more resource intensive.
Right.
There are more people involved. There is a lot more investment into a C-section. So you will charge, let's say, 125 rupees in between a vaginal birth and a C-section. Now, if we accept the common understanding that a C-section rate is 40%, then it stands to reason that the rate of your vaginal birth 60%.
Yeah.
Which means that if you were going to charge 100 rupees for a vaginal birth, but now because of this, in a way, monkey balancing, you're going to charge 125, aren't you penalizing 60% of the women for giving birth vaginally by charging them 25 rupees more? It does amount to almost a 30% surcharge, in fact, or a tax on giving birth vaginally. Isn't it? I mean, just simple back of the envelope calculation.
30% more for giving birth to C-section.
Vaginally. Now you say that, all right, so to take money out of the equation, let me charge the same for both.
Okay.
You will not charge 100 for a C-section. You have to charge little more because C-section is more resource intensive.
So you're saying you charge in the middle.
125 for
both,
everybody.
For both.
But if you charge 125 for everybody, 60% of the women who are giving birth
are paying the
vaginally,
25% extra. That's what you're trying to say.
Exactly. So you are in fact penalizing women.
So you're a proponent of do the 100 and 150
Absolutely.
and don't make it 125.
Yes. And
so there are different ways of thinking about the same thing, which is fine. But I think we need to be aware of all different aspects. But also in C-section, isn't it true that the woman has to stay in the hospital longer? So I remember I had both normal deliveries and I was out the very next day.
Yeah.
I delivered at 5 in the evening, next day 10 a.m. I left.
Well, you mustn't have delivered in India.
Sorry?
You mustn't have delivered in India.
No, actually, one was in the US. One was in the US.
Yeah.
I did that. One was in India, but I still did the same thing in
Yeah.
India as well.
Yeah.
Maybe I got my way, but
Yeah.
I was out by 10 a.m.
Yeah.
And my thing is with a C-section, aren't you there mandatorily for longer? What is the minimum period post-delivery? Because it takes longer to heal the stitches.
No, I don't think so. Here even in India, we try to discharge people in a window between 48 hours to 72 hours. Yeah. Even if it is a normal birth.
C-section versus normal?
Normal birth, vaginal birth, cesarean birth, discharge time is the same.
The discharge time is the same?
Yes.
So I obviously delivered
Well, those are different.
20 years back, so maybe a lot of myths in my head, which is what I want to get to right now. My mother also told me that, both of you are gujus, pet rahe jaise. Your little tummy will stay with C-section, whereas with normal you can have a flat tummy. All these are myths, right?
Complete
so can we
myths.
talk about some of these myths of, we can start with you, go on to you, but C-section versus, let me not keep saying normal. C-section versus vaginal delivery. What are some of the myths? I
Vaginal
just
birth.
addressed two right now, right?
Yeah.
Vaginal birth. We're not Zomato here. Yes. Oh God, too much for me to remember today.
No, I think one of the important things to realize is that things have changed.
Yeah.
And there is this whole cultural overhang and even a medical overhang to say that if you had a cesarean birth, you will take longer to heal.
Yeah.
It honestly, for me, doesn't take into account the fact that even vaginal birth's a major health event in a woman's life. And I think this is something which we don't address as much, and it probably comes from the fact that vaginal birth's called normal.
Yeah.
Because if something is normal, how can you take time to recover from that? Right? It's not only about the physical recovery, Nabita. A birth is a very significant event, not only in a woman's life, it's a significant event in that entire family's life. And I think the time to recover, to rest, to recuperate, and also to get comfortable with the baby is something which we don't take into account. We just look at the stitches and say, right, your stitches have healed, you're healed. That's simply not true. Right? It's so much more than the physical healing.
Yeah.
There is this whole thing. Imagine someone gives birth for the first time. She is in the bed, the child is there, the child is crying. Now imagine the pressure that woman feels to breastfeed that child successfully.
Right.
Right? So it's not about the physical healing. Anytime the relatives come, they will ask, you're Gujarati, Jai is Gujarati, so they'll ask, Doodh aavech ke nahi?
Of course.
Yeah, of
You
course.
see, and the whole thing is that again, because breastfeeding is normalized, we say maa ka doodh ka karz in all these Hindi movies, right?
Yeah.
And we feel that breastfeeding is something which should just happen spontaneously and naturally. People don't realize breastfeeding is an art.
Yeah.
Breastfeeding takes time for both the woman and the child to learn.
Right.
And the recovery time after a birth is not only for the woman to heal physically, it's also a time for her to get adjusted and to be comfortable with the child.
Right.
I think this whole perspective is hardly ever talked about.
Yeah.
Personally, honestly, you did it, but I'm not in favor of very, very early discharges. Like Jay said, we do discharge in 48 to 72 hours, but I always tell the patient at the time of discharge, we will discharge you when you are comfortable.
Right.
From my side, you're now ready to go home. But if you think you need to spend an extra day, please do.
Okay.
All right. My wife is a pediatrician, so she comes and takes rounds on the babies. And then I do ask her, do you think this baby and the mother are ready to go home? And if we think that they are ready to go home, we tell them, all right, now you can go home medically, but mentally, if you think that you need a day more, please stay back.
Again, it's a matter of choice.
Absolutely.
Dr. Jay?
I was speaking to somebody, and based on what Jaydeep sir so nicely mentioned, that it's just that particular 3 days in the hospital which we look at. See, there is a reason why maternity leave is granted for 6 months. Otherwise, if the recovery was to be so quick, it should be a 15-day maternity leave.
Yeah.
As sir mentioned, the amount of effort, which probably goes into the breastfeeding aspect, the amount of effort which otherwise goes into the body to return back to the original state, is any which ways around 7 to 10 weeks post-birth, which is why, even for the medical guidelines, we look at 42 days post-birth
Right.
to be a part of the maternity window. And I think people really need to probably understand that.
Postpartum depression.
Yeah, big thing.
That's a real thing, and the numbers are large. And you need time
And
to,
it's-
like you said, mentally also deal with the big change in your life.
It's going to grow because we are no longer, as you were asking me, like what's changed, with the generation. I think what we end up delivering is majority people coming in from nuclear families, like just the two of them.
Yeah.
Right? and the two of them think that they know everything about the subject.
Yes.
And I think
Google
that
masters.
maybe so. I mean, I may not want to call it Google masters or whatever masters. It's just that it's their anxiety which goes them into the reading, and what they process is just information. Now, how to convert information to knowledge probably takes 5 years of post graduation, and then 28 years and 15 years of experience after that to grow.
Right.
And I think that is what people actually miss out on. People really think that, okay, I read that, this should be that. But then if let's say Dr. Jaydeep goes and tells them that, yes, it should be that. But
Tell
for
me
your
top three
case,
myths. I know you're very big on social media. You even do Insta live surgeries.
Yeah.
So I want to know, what are the top 3 myths that you try to bust through your YouTube channel, your social media?
when you look at maternity as such, one big myth is that if you've conceived naturally, you've got an achievement.
You glorify it.
You've glorified that you've conceived naturally, as against to somebody who has taken some assistance for conception, which is equally good. I mean, there is nothing wrong in taking some assistance for conception.
Yeah.
By that logic, you should simply not visit a doctor, isn't it? The second, I think, and probably I am right or wrong, or probably it's just my view on this, is that people really try to think that doing some form of supplementation in pregnancy, some form of yoga, some form of exercise, some form of this is going to make sure that they have a vaginal birth.
Oh.
So that's the feeder, that you want to have a vaginal birth, you should start exercising, you should do your pelvic floor, this thing, you should do that, you should do a pregnancy yoga, and it's okay. But I personally think a lot of times the couples in today's time and age genuinely do not have the financial resources to go in for all of that. It'll be really good if that has a guideline that gets addressed, and a good financial allocation is done as a reserve fund if something is required for the child. That is the second thing which I really try to do. The third thing, which again I have tried to do over the last 10 years, I am not a big believer, and I don't encourage people to come under the social pressure and do cord blood banking. As soon as people who are
I'm glad
registered,
we addressed that, because that's a very big choice
it's a social
again that
stigma.
people have to make.
I mean, you are a group of 10 friends, 4 have done it. De facto, the 5th one wants to do it because the other 4 have done it.
And you feel like you're not doing enough for your child. There's that guilt.
Yeah, it's a guilt feeling. And there is no recommendation from, I think, the body of gynecology. There is no recommendation from the body of pediatrics which tells you that, by not doing it, you are doing something wrong. It is an add-on which is to be taken with a great amount of caution.
Right.
And I think that is something which a lot of couples, they don't understand. See, they've budgeted their pregnancy at, let's say, 1 lakh rupees. If you look at an Indian perspective, suddenly the stem cell is going to give them another 35,000 rupees of cost, which I think can be used so much more effectively for pediatric visits, vaccination of the child, diapers, hygiene of the child. So many more things in an Indian situation.
That's a good point. So if you're constrained for resources, be very careful where you're spending them. And then 2 quick things I want to ask you is, one is epidural and episiotomy. Because both of them, I told you, I had to deal with, and I didn't know what I was doing. So firstly, tell the audience what it means, and then what your views are, and then you can talk about that as well.
Epidural is basically some type of pain relief which is offered at the time of, giving any form of surgery. Now, this could be any surgery. This could be at the time of vaginal birth, cesarean section, cancer surgery, knee surgeries, everything. It is just a form of regional anesthesia. That is epidural. There are certain specifications which are done in pregnancy by your anesthetist. They may
I was almost told don't take an epidural because the pain is glorified. The pain during your birthing process is glorified.
It's a good content, that you went through so much pain and you came out victorious like a gladiator.
Yes.
But I think you can be a gladiator even without pain.
Yeah.
Correct?
So there's nothing wrong with taking an epidural.
I think
it's not going to harm your body. Then.
No, it's really safe.
Yeah.
It keeps
I think people need to hear that.
It keeps you so happy post-birth.
Yes, absolutely.
People sleep through that night. Post-epidural, you give that shot of epidural with the catheter in. Let's say somebody has had a cesarean section or even a vaginal delivery with a instrument like where episiotomy is mandatory to cut a part of the vagina so that, the baby can come out easily.
Episiotomy is where you cut the vagina so baby comes out more easily.
More quickly.
Even that was something I was like, do I need to do it? I mean, there were so many myths in my head for my first pregnancy.
in government medical college where I studied, and probably even sir is from there, so KEM and Wadia, as interns in obstetrics and gynec department, we really used to love, taking the baby out and helping somebody in doing that. The first thing which we were taught is how to give an episiotomy and how to stitch it back. I think, from my perspective, it is something which is phenomenally good.
Yes, absolutely.
Dr. Tank.
About epidural. I'm a firm believer in pain relief. I think this whole thing about pain is honestly unnecessary. It's like saying I have a headache but I won't take a Crocin. For my patients, the simple way that I explain to them is, imagine you're getting your tooth removed. You take an injection to deaden the tooth, but it doesn't stop your mouth from working, right? So the epidural injection, in fact, is the same thing. It's the same local anesthetic that is injected in the tooth. Instead, we deaden the nerves which produce the pain.
Right.
It means that you won't feel the pain, but whatever else has to happen with the uterus and the vagina continues to happen. So liken it to deadening a tooth at the time of extraction. About episiotomy, again, a relatively simple way of looking at it is that there is a limited amount of space in the perineum. When the child comes out, the perineum has to give way. It could either give way with what is known as a perineal tear, which is an unintentional, non-surgical tear, or you could give a deliberate surgical incision and make sure that, in a way, the amount of perineum that is cut is limited.
Correct.
This is my perspective.
Correct.
People don't necessarily agree with both perspectives. But I would say very strongly that where it's required, an episiotomy would be preferable to a woman having an uncontrolled and, how do I say, I believe the younger generation calls it random tear.
But we spoke earlier about even good friends of yours and mine. There are doctors who are for and against an episiotomy. So why would some very, very reputed, very well-established doctors tell a patient that don't do an episiotomy? What's going on in their mind? Because I think patients need to hear both sides of the story.
I don't think they say don't do an episiotomy. I think the philosophy is to avoid it as far as is required.
But why? Why?
The feeling is that you're protecting the pelvic floor. Because suppose you don't give the episiotomy and she manages to give birth without the perineal tear, then she'll have an intact perineum. That is the
But
philosophy.
if you don't have an intact perineal, if you're just going to stitch it up, it self-heals, right?
Exactly,
So if
which is exactly my point.
Why is it bad if you...
It's not bad. I think that's the whole thing.
Okay.
Right? An episiotomy...
You're just normalizing everything that...
Yes. An episiotomy is not bad by any means.
Yeah.
For me, it's a choice between an uncontrolled tear versus a controlled surgical incision, and a controlled surgical incision is always better.
Got it.
And I think one of the biggest myths that is prevalent is that every time you get pregnant, you have to have the perfect outcome. I think it's putting so much pressure on modern pregnant women. And I always say this, I don't want to say I feel sorry for them because that would be condescending. But I certainly feel a lot of empathy for them.
Yeah.
Starting from the WhatsApp messages in the family group, don't take stress, be calm, think good
That
thoughts,
itself would give you stress.
Exactly. I mean, never in the history of being told to calm down has being told to calm down anymore.
Yes, exactly.
Right? So I think I'll just tell you the story to illustrate what I'm saying,
sure.
right? I had this patient who used to come to me quite a few years back. And every time she used to come, the entire family used to come with her. And when I say entire family, I mean entire family. Like 7 people used to accompany her.
That's a typical Gujarati family visit.
And then I used to examine her. Then all of them used to ask questions. And then at the end, they would point to the girl and say, Beta, tamne kai puchu che? Ab ye su puche?
I know.
I mean, she's surrounded, exactly.
Yeah.
So then after a couple of visits, I told the relatives that, see, everything seems to be going fine. Why don't you just let the couple come? And I'll call you as and when, it's needed. She came again next time with her husband. I examined her. You know what she asked me? I said, look, everything is going fine. She said, Doctor, I want to ask you something. I said, yeah, sure. She said, my co-sister-in-law, I believe there's a term like that. My co-sister-in-law is also pregnant with me. Yesterday, she vomited 6 times, but I vomited only thrice.
Oh my God.
Does that mean her pregnancy is better than mine? I mean, talk
These
about
are the
myths.
kind of myths. Oh God.
You
Yeah,
see,
yeah.
I mean, just imagine. And initially, I felt a little amused. I said, why is she? And then at the end, I was feeling so bad for her. I mean, imagine thinking that you have to vomit more times to prove that you have a better pregnancy.
My God.
You know, Namita, if you Google childbirth, you get more than 16 million results. And most of this information, sad to say, is simply not authenticated and not true.
Right.
This is the kind of rubbish that our pregnant women are basing their knowledge and information on.
Absolutely.
You know, and that is causing all these kind of, you know, pressures. And I went home and I told my wife that day that, you know, I'm just feeling so helpless, you know, that I cannot do anything for her.
Yeah.
You know, but how much information can I provide? And she's not the only patient I had who came to me that way.
With
So
these
I
kind of
think this
questions.
biggest myth is this quest for a perfect outcome every time. It has to be a vaginal birth. The child has to be 3 kilos and the child has to come first in 10th standard.
And
Everything is expected,
everything they make you
you
eat.
know,
I was asking you that. Everything they
Exactly.
make you eat,
Yeah.
that's going to make your kid more intelligent. You start in your pregnancy. It's
Exactly.
insane.
It's so much pressure. I mean, you know, if you don't do this, the
There's
child
fear.
will have this outcome.
That guilt and fear
You know, it's like
overload.
this. Every month, I lose out on 3 patients for delivery because
Birth.
sorry. every month I will lose out 3 birthing opportunities.
Yes,
Let's
birthing
call it that way.
opportunities.
3 birthing opportunities.
Hey, you gave birth in his clinic.
Yes, that's what.
You better follow whatever he tells you.
No, I do that. I do that religiously. So you know, every month we'll miss out on 3 of them because the relatives have a belief that, you know, our doctor to just said you eat everything.
Yeah.
He's such a bad doctor. That's why he is so young and inexperienced. Which is the exact reverse.
Yeah.
You know, for a doctor to tell you that eat everything, it's probably a sign that the doctor is very good.
Yeah.
The doctor has told you to enjoy your pregnancy. Like, I think this is the actual enjoyment.
Yes.
Yeah.
When you tell somebody that, you know, you what? Go to office. I had somebody who recently blogged about it. She was working till 39 weeks, 2 days or something. She came from her office to the hospital for her birth. Right. And she blogged about it that, you know what? I didn't do any diet. I didn't do nothing. I never went for yoga. I continued to work.
Right.
Isn't this a happy pregnancy?
Yeah.
And there will be a society where people are very happy accepting it. There'll be some guys who will say, oh God, he's not even giving you a diet. Oh my God, he told you, he didn't give you like pelvic floor exercises. Like, is the doctor qualified or is he like fake?
Got it.
Right? And this is going to be like a good content, you know?
No, and in fact, coming to that, I remember that if you were a very slim pregnant woman and didn't put on a lot of weight, people would be worried. Okay, why aren't you putting on weight?
Yeah.
Why aren't you putting on weight? And I think you're not supposed to put on more than 8. I mean, even if you put on 8 kilos, that's okay, right?
As long as the child is putting on weight.
Yeah, as long as you're meeting those milestones. But
Correct.
it was almost like being a skinny pregnant woman was looked down as like you're hurting the baby by being skinny.
No, I think this whole concept about weight, Namita, is again a cultural overhang. It comes from the days when there was no ultrasound to gauge the health of the child.
Correct.
And weight gain used to be seen as a measure to estimate how healthy the pregnancy was.
Yeah.
So it was that if you're putting on weight, then your child is also putting on weight. People don't necessarily understand or realize that at around 28 weeks of pregnancy, the fetus would weigh anywhere between 1 to 1.2 kilos.
Correct.
In the total context of the whole thing, a healthy fetus weighs anything between 2.5 to 3. Anything more than 2 is considered all right.
Correct.
So if you're going to put on 12 kilos and use weight as an index for fetal health, the difference is only 2 kilos.
Exactly.
So if you're putting on 12 kilos, your fetus is actually only 2 kilos, right? So as I said, it's a surrogate measure for the health of the fetus.
Got it.
Right? We now have ultrasound, which was not existent when weight used to be so emphasized upon.
Right.
We now have ultrasound, and I always tell patients that don't use your weight as a measure for both your health and the fetal's health.
Yes.
We have ultrasound, we know exactly how well the fetus is growing. Whether you put on 5, 6, 8, or 20 kilos is not an index of how healthy your child is.
Absolutely. I want to touch on one last question, which I know you're very passionate about, which is recurrent pregnancy loss. Why does it happen? What are the key reasons?
If you start analyzing recurrent pregnancy loss, Sir mentioned one very nice data that 45 million pregnancies in the country, out of which, let's say 16 million of them would probably have a medical termination of pregnancy. It is important that we are left with 30 million, right? Out of these 30 million pregnancies, there will be approximately close to 15 to 20% of them, which would simply abort on its own.
Right.
When I use the word recurrent, okay, that is when this episode of you having an unplanned abortion,
Right.
or a missed miscarriage, whatever you may call it, has happened at least more than 2 to 3 times.
More than 2 to 3 times, yeah.
I think a lot comes down to, again, the social status, right? If you've lost a pregnancy once, you are anxious. Obviously, with the type of information you have available, you've got people coming to us in the first act of, missed abortion, questioning that why am I not going ahead and, testing the child as to what went wrong.
Yeah.
Whereas there is simply no guideline to support all these things.
Right.
We may want to evaluate people based on hundreds of causes, and believe me, out of every 100 you evaluate, 70 of them will again come back to you with no known cause. Unexplained. And that's why people want to delay the evaluation for at least having 2.
Correct.
Such
So they see a
episodes.
pattern.
They see a pattern.
Got it.
And I think only then people should be actually evaluated and be branded as recurrent pregnancy loss. Because I think in today's practice, and I'm sure Jaydeep sir would also be seeing that, patient has had one abortion and has done investigations worth 75,000 rupees.
Right.
Most of them are normal. They've come to you and they're going to be asking you, what do I do to make sure that this doesn't happen the next time? And the answer is you pray.
Yeah.
Correct? Because there is nothing in science which can allow us to change the outcome which has been predefined by nature.
This is majority of the cases, but there are some cases where it is predictable.
Absolutely.
Because they come with certain basics where you know that their probability of
Absolutely.
getting it is higher.
Absolutely.
So let's talk about those that are predictable. What are those top 5 reasons where you can say that she has a higher chance of having a miscarriage?
So you can broadly divide them into very quick things. One could be genetics.
Correct.
You can't change your genetics, but you can test your genetics.
Right.
It'll give you an idea if you're going to have future abortions.
Got it.
You can't change the genes, but you can test your embryo before putting it inside. So that is some correction which you can do.
Right.
Second thing which is nicely correctable is anatomical problems. Very commonly you can see polyps, fibroids, septum inside the uterus, all these types of things. Easily correctable. You can do a small quick corrective surgery and usually people will have very healthy pregnancy outcomes after that.
Fantastic.
Third and fourth would be predominantly related to biochemistry. That means somebody could have elevated levels of, clotting agents in their bodies. Somebody could have low levels of, anti-clotting agents in their bodies, easily manageable. You can give them simple drugs like heparin, ecosprin, and the patient will do very well in their pregnancies through this. One more interesting and important cause, especially in India, and completely correctable, is endocrinological causes. You'll have a lot of women who have never been tested for any endocrinological workup, let's say hyperprolactin levels, hypothyroid levels.
Correct.
They have elevated levels of thyroid. They simply didn't know about it.
Right.
Correct. They got pregnant, they got married, life is going smoothly, nothing came to their, sight. They had 2 abortions, they got tested for a thyroid. They knew that they require thyroid correction. The thyroid is
So
corrected.
these are things that can very quickly be checked before you get pregnant.
Absolutely. And that's why it's all becoming a very important part of preconception now.
Right.
That when somebody's planning conception, planning the perfect conception, as Jaydeep sir mentioned.
Doesn't exist. But one quick question on this, because you spoke about thyroid, gestational diabetes, high blood pressure, very common nowadays during pregnancy. Has the rate gone up over the years?
I would say surveillance has gone up.
Okay.
Apart from
Awareness has gone up.
So we have become better at picking it up very early. Like these days, we are predicting it at 12 weeks, ultrasounds and biochemistry.
And there's nothing to worry, right? Like if you have some of these things, it's okay. It is very correctable. Women don't have to panic, right?
But even if you tell them not to panic, they will panic.
Yeah.
Because
Not
because the tagline is to panic.
Yeah, but in your medical opinion, in your expert opinion, developing this during pregnancy is normal and not to cause panic.
So, for thyroid, for example,
Yeah.
you could have thyroid disease, but as long as it's under control, it will not have an adverse outcome.
Right.
The problem is when it's not controlled.
Right.
Similarly, for hypertension, as long as you have detected it and it's controlled, that's fine.
Right.
For recurrent pregnancy loss, Namita, I think it's very interesting if you really think about the threshold of defining recurrent pregnancy loss. Jay just said 2, 3. And this is something I tell my patients, that the chances of anyone getting pregnant and having a single unfortunate event or a missed abortion is 13%. If that same patient gets pregnant again, contrary to popular belief that if I've had one adverse event, I'll have another adverse event, that patient who had a 13% chance of losing a pregnancy the first time now has a 3% chance of losing the next pregnancy.
Okay, those are the numbers.
And if she conceives third time, then her chances of having an adverse outcome is less than a percentage point.
Right.
People always feel I had a problem earlier, so the chances of my having a problem are more.
And it's actually the
The
opposite.
reverse is true.
I'm glad you brought out those statistics. It's important for people to know this.
Exactly.
Very true.
So if you work in, so depending on which side of the Atlantic guidelines you follow, in the UK, they define recurrent pregnancy loss at 3 losses or more. And that's why the incidence of recurrent pregnancy loss in the UK is somewhere between 1 and 3%.
Right.
In the US, they define it as more than 2 losses.
Right.
And their incidence of recurrent pregnancy loss is between 5 and 10%.
Because the cutoff is lower.
Exactly.
So that's just a numbers game.
I think I would agree with Jay that there is a lot of this whole thing about wanting to do something.
Right.
All right, I had something bad happen to me. I want to know why it happened. It's a natural human desire. But the fact of the matter is that these are certain things which occur in nature.
Right.
And there is not a whole lot that you can do to control it. And at some point in time, one just has to accept the fact. So you do your basic investigations after one loss. There's no need, as Jay said, to do 75,000 rupees worth of investigation.
Correct.
Yeah.
You just do the basic investigations, and if everything is fine, then you just sit back, try again for a pregnancy, and understand the fact that next time, the chances of succeeding even without doing anything special are pretty high.
So don't panic.
No, don't.
It's by the textbooks, you know. Sometimes doing no treatment is actually a treatment.
Yes.
My God. I don't know about you guys, but my head is spinning because we spoke about way too many things. We spoke about C-section versus vaginal. We spoke about a lot of myths, and we spoke about epidural, episiotomy, 2 important ones. Recurrent pregnancy loss, a very important topic, and what causes it, and the thyroid aspect, the hypertension aspect, and the best part was the myths that we busted. So I think we really covered a whole lot of things. I like the emotional part also. I think there has to be a separate episode on postpartum depression. That is such an important topic that we need to cover. And in that, we can weave in the breastfeeding part as well. So this is a topic that definitely we cannot do justice in one episode or in a short while. So we hope we can call these lovely experts back for part 2. But till then, thank you very much. Lot to learn, lot of myths busted, and hope you all learned a thing or two, and make sure that any pregnant woman around you can share this information so they don't panic and they stay calm and happy and enjoy this beautiful phase in their life. Thank you.